Hi, good morning, everyone. Thank you for coming to MGB Neurology Grand Rounds. On behalf of the Chief Residents, I'm very happy to introduce today's Grand Round speaker, who's one of our own faculty here at MGH. So today we're going to be hearing from Dr. Stephen Arnold, who's Professor of Neurology in the E. Gerald Corrigan Endowed Chair in Alzheimer's Therapeutics here at MGH. So Dr. Arnold received his MD at BU, and then he completed both neurology and psychiatry residencies, and then had a long career at the University of Pennsylvania, where he was the director of the Penn Memory Center and associate director and clinical co-leader of the Alzheimer's Disease Core Center and associate director of the UPenn Institute on Aging. About 10 years ago, he moved here to MGH to lead the Alzheimer's Clinical and Translational Research Unit, conducting early phase clinical trial and biomarker research. He also serves as the managing director of the Interdisciplinary Brain Center, which is a collaboration between the departments of neurology, psychiatry, and the Martino Center for Neuroimaging. Dr. Arnold has a long career of conducting research on neurodegenerative diseases, including molecular biomarkers and therapeutics. He has led broad clinical and translational programs. He's really interested in CSF biomarkers and how they correlate with pathology. He has done a lot of work in discovery and validation of those biomarkers and staging of dementias, as well as novel early clinical trials for neurodegenerative diseases. He's authored more than 400 papers, reviews, and chapters, and he's currently interested in biomarkers, immune and metabolic factors in dementia, insulin resistance in the brain, as well as protective factors for cognitive resilience, with the goals of accelerating therapeutics. So today he's going to be talking to us about blood-based biomarkers for Alzheimer's disease and related disorders in clinical research and clinical practice. Welcome, Dr. Arnold.
Well, thanks very much. And really, it's a pleasure to be here with you all. Here we go. Here's the disclosures. So I'm going to be talking about blood-based biomarkers for Alzheimer's in clinical practice as well as clinical research. And I think it's been a long time coming, but we're finally about ready for prime time in terms of blood tests for Alzheimer's disease. And I'm going to take you through some of the data that makes me say that. I'm going to largely focus on phospho-tau biomarkers because that is what has emerged as the strongest and most robust of the biomarkers to help us in terms of diagnosis, prognosis, and probably treatment monitoring as well. So let's see here. Disclosures again. So we've all seen this slide year after year. This is from the Alzheimer's Association showing the scope of the disease that we're dealing with here. Alzheimer's disease currently affects about 6.5 million people in the United States. Just to put this in context, stroke, either death or disability, affects about 7 million people per year. MS, 1 million people per year. Parkinson's, 1 million people per year is the prevalence. ALS is about 4,000 or so, I think. So this is a big, big disease that we're dealing with. Until recently, we've been working with essentially clinical criteria for making a diagnosis of Alzheimer's disease during life. These are the McCann criteria from 1984, and until recently, the last few years, we would evaluate patients with a cognitive disorder. We would look for some kind of memory predominant decline from a previous level of functioning in older adults. And then we would look for other neurologic conditions or medical conditions that could be contributing to it. And if all of that was unrevealing, then we would make the diagnosis of probable Alzheimer's disease. And you basically say that to your patient and then wait until autopsy when Dr. Frosch would tell us what the patient really had. And even the best neurologists would be right 70% of the time, 80% of the time, not much more than that. It's actually interesting. The first patient in ADNI, the Alzheimer's Disease Neuroimaging Initiative, who was diagnosed with Alzheimer's disease, was followed, and the autopsy revealed a dementia with Lewy bodies predominant as the cause of the dementia. So even in the best, research hands, we still are short in terms of diagnosing this accurately. And this, of course, becomes critically important as we enter the age of disease-modifying therapies. But things have changed. Over the last 30 years or so, there's been further and further development of biomarkers in terms of amyloid and tau PET scanning, CSF biomarkers that have just gotten better and better, and more data have been accumulating from those, to the point now that we have redefined Alzheimer's disease with criteria that include biomarker, and to the point that the clinical syndrome is no longer even necessary to establish a diagnosis. Basically, what people are accepting now is that if you have the characteristic neuropathology in the brain, then you have Alzheimer's disease, irrespective of whether you have memory problems or other cognitive decline or functional decline. Whoops, here we go. So what is this neuropathology that we're now defining the disorder, that we've always defined the disorder for? It's the plaques and the tangles of Alzheimer's disease. And this shows what Alois Alzheimer might have seen under the microscope over 100 years ago when he studied the brain tissue from a young woman with a genetic form of Alzheimer's disease. She was in her 50s, who had a severely progressive dementia, and in autopsy, using the new silver stains that were investigated at the time, and found and described these neurofibrillary tangles and neuritic plaques that we see here under the microscope. This is a slide that I've been using for, I don't know, 15, 20 years now, but I think it's still accurate. And it describes what we have learned about these neuritic plaques and these neurofibrillary tangles of Alzheimer's disease. That amyloid precursor protein, which is a normal protein that we all have and we make, becomes abnormally processed in such a way that the molecules clump together into oligomers, which clump together into plaques, the diffuse plaques, which start to involve neurites, and then we get neuritic pathology that can elicit an inflammatory response, and those are the amyloid-centric neuritic plaques of Alzheimer's disease. The other key pathology is with tau, the microtubule-associated protein tau, which can become hyperphosphorylated and also form fibrils within neurons, ultimately disrupting the function of neurons, and we think lead to cell death, although Dr. Hyman will tell us more about that at some point too. So this is how we define Alzheimer's disease, plaques and tangles. And we have now developed key blood-based biomarkers that hone in on these defining lesions. So we can measure amyloid through PET scans in CSF and in blood. We can measure tau and phosphorylated tau in PET scans and CSF and in blood. And we can look at other aspects of this disease process, including neurodegeneration with markers like neurofilament light, or astrogliosis with markers like glial fibrillary acidic protein. So I'm going to go through some of these. the way that the blood-based biomarkers have evolved has really come, starting from pathology, then to PET ligands or CSF, but mostly through PET ligands is how we've convinced ourselves. So here we see Pittsburgh compound B staining some tissue sections and the corresponding amyloid plaques seen in histopathology. Chris Clark, a former colleague of mine, did a wonderful study when he was at Avid where they recruited patients who were basically in hospice, who agreed to have autopsy at the time of death and amyloid PET scan with the new tracers that were being developed at the time. And in this series of about 100 people, as I recall, there was extremely high correspondence between what you'd see with the amyloid PET and the post-mortem evaluation. Virtually 100% specificity, perhaps a little bit less sensitivity, 95, 96% there. Then we move from PET to CSF, and we see very good correlations between CSF biomarkers for amyloid and the corresponding amyloid PET positivity or negativity here in the Washington University of St. Louis cohort, and here in the BioFinder cohort, which is a really large and extremely productive study based in Sweden of longitudinal follow-up of multiple cohorts, actually, and we'll be talking about BioFinder a little bit more. Same thing has been done with tau and tau pathology. Teresa Gomez-Isla and Cynthia Aguero had a recently published paper where they looked at the binding of different tau PET ligands to pathology, again, finding very high correspondence to Alzheimer's disease tau pathology, but curiously, and we'll see this in the biomarkers as well, not to other tau disorders, not to other tauopathies. So moving from histopathology down here into PET, again, seeing good correspondence between pathology for Alzheimer tau and in Alzheimer disease, between tau and histopathology, and then moving on from PET to CSF, again, showing very good correspondence to CSF. So, it is based on studies like this that those revised criteria were based, because the correspondence of these biomarkers, whether they in vivo, whether they be in PET or in blood, is so good that we now accept them to be proxies of the histopathology. Whether that's true or not, or fully 100% true, is still a little bit shaky. The specificity actually looks good. The sensitivity may not be as good. And so what we're seeing now as we develop these biomarkers is that we're going from histopathology as the the platinum standard, and then we're using amyloid and CSF that may have maybe 96%, 98% accuracy overall. And then we're using now amyloid and CSF, PET and CSF, especially as these are now our new gold standards against which we are developing new tools such as blood-based biomarkers. So sometimes I wonder that there's a little bit of noise that might get expanded there. And I think that that's one concern that we have to just keep in mind and think about, and some of us worry about. So in developing blood-based biomarkers, there have been some real challenges. You have to realize you get about 20 milliliters of CSF turnover per hour, and that is getting absorbed into the 5 liters of blood. So there's like you have small amounts of coming from the brain, diluted about 250-fold in a plasma. there's not a whole lot of concentration of some of the CNS-specific molecules there. And you have to realize that, it's getting into blood, it's getting hugely diluted. Then there's issues of metabolism going on in the blood, excretion through the kidney or the liver, binding to other proteins in the blood. All of this can affect the levels of these. So we've got a real sensitivity issue in terms of detecting, CNS-specific or Alzheimer-specific molecules in, an ocean of blood. And so it's been a real challenge, and I would say a real triumph of analytical chemistry, that we now are able to detect, super low concentrations of these molecules. And there's been two major ways to do this. One, through immunochemistry, where we have developed new instruments, automation, and especially the antibodies, which have extreme sensitivity as well as specificity that can detect amyloid, different species of amyloid or different species of tau, and the like. So these are a few of the instruments that we actually have in the biomarker core lab. Electrochemiluminescence detectors with MSD and the Fuji-Rabio Lumipulse. There are now single molecule array that are taking advantage of microfluidics with the Quanterix Simoa system, and then some other companies like Olink and Alamar and Spear that are using these proximity extension assays, attaching a little piece of DNA to antibodies and then amplifying that. These are the things, and this and some of the secret sauce of the buffers and all that suppresses the noise. These are the things that have boosted the sensitivity and the ability to detect very low concentrations. Mass spec is another way. But again, mass spec has some limitations in terms of its sensitivity on its own. So you usually have to use immunoprecipitation as well. This introduces some new steps, new labor, and perhaps a little bit more noise. Nonetheless, the specificity and the range of proteins that you can detect and the isoforms of proteoforms that you can detect with mass spec is superb and makes it worth it. So what have we learned applying some of these methods? Let's just start with amyloid, which is the sine qua non of Alzheimer's disease. If there's not amyloid, we don't call it Alzheimer's disease. So looking at amyloid-beta 42, which is one of the pathological species of amyloid-beta, and especially the amyloid-beta 42 to 40 ratio. This is pretty much what we've seen, at least with the immunochemical methods for Alzheimer's disease, that it's got okay discrimination ability. You can see the ROC curves. We've got accuracies, approaching 80%. That's good. It's not great. You can see the overlap, between people who are, again, against the gold standard of PET, amyloid positive versus amyloid negative, that there's a good degree of overlap. And so, these are the kinds of curves and accuracy for amyloid beta. We've done some work in the lab a number of years ago, Becky Carlisle and Pia Kivisak, where, again, basically we're showing pretty much the same thing. We see reasonable correlations between CSF and plasma, 42-40 ratio, a lot of overlap in plasma. And then looking at the 42-40 ratio for its discrimination ability based on CSF as the gold standard, we see that it's inferior to some of the other biomarkers that I'm going to be talking about. The immunoprecipitation mass spec does better. So if you can pull down the amyloid and then look at the the species and create a ratio in that way, you get a better discrimination. So Shimadzu in Japan and C2N based in St. Louis coming out of WashU, have been looking at this and using this and actually commercializing these. And what we see is, let's just look at the WashU over here. We see better looking discrimination between PET positive and PET negative cases when we look at the amyloid beta 42/40 ratio. And we see good correlation between plasma and CSF using this method. And if you just use that method for plasma, in plasma, you get about 88% accuracy reported. If you then add things like age and ApoE into your model, you can boost that up to, perhaps 95%. And, the analytical chemists love to do head-to-head comparisons. So looking at all the different kinds of assays, they're pretty consistent. For amyloid beta assays and its ability to diagnose and associate with amyloid PET, you get good association, but certainly not great association. In the order of 70 to 80. And if you go to the IP mass spec methods, you can boost it up to 90 or so. So it's good. It's a contribution, but it's really not good enough. So let's talk about tau. So tau, as you know, is a microtubule binding protein. It binds and stabilizes microtubules, giving shape or flexibility to neurons. There are a lot of post-translational modifications in tau, both in development, in terms of plasticity, but then also in pathology. And what is seen in tau is that in Alzheimer's disease, both in pathology as well as in CSF, is that tau is highly modified post-translationally, and particularly what we focused in on is the phosphorylation, and in particular for both, I think, theoretical as well as practical reasons. As you'll see, the pTau, phospho-tau 181, amino acid 181, 217, and 231 have emerged as the most informative in Alzheimer's disease. So what do we see with pTau 181? Because this is the one that we've used in CSF for many years, and you can measure it in plasma. And again, you see good to very good discrimination. So here, this is in ADNI, the Alzheimer's Disease Neuroimaging Initiative cohort. We can see that comparing people with cognitively unimpaired people to people with mild cognitive impairment to AD dementia, that we see a steady increase in the pTau levels. If we look at people who are either positive or negative for amyloid presence in the brain as determined by PET, I believe. Again, we see those who are amyloid positive in each category have higher pTau 181 levels. And looking at the amyloid positive versus negative people, we are seeing AUCs or accuracy for discrimination in the mid-80s there. Again, very good, probably an improvement over the amyloid beta 42/40 ratio. So it's good. It's an improvement. So we started using 181 in all our work, and then 217 came on the stage, and plasma and pTau 217 has shown remarkably good discrimination of people with Alzheimer's disease versus non-Alzheimer disease. As you can see here, in this, these are three cohorts, the Wisconsin cohort, the triad, and the spin cohorts. Really good discrimination between people who are both tau PET and amyloid PET negative, people that are amyloid positive, tau negative, have an increase. So we're not able to detect tau yet with PET, but the amyloid is present here. And then here we have people that are both amyloid and tau positive, and we see a stepwise increase in the pTau 217 level. And we are getting accuracies now in the low to mid 90s in terms of percentages for discriminating amyloid positivity and tau positivity. Differential diagnosis, of course, is critical in our field. Is this Alzheimer's disease? How does pTau 217 look in relationship to other neurological or neurodegenerative diseases? And we do see that pTau 217 is specific for Alzheimer's disease, dementia, and Alzheimer's disease, mild cognitive impairment here, compared to other conditions like Parkinson's and Parkinson's dementia, progressive supranuclear palsy. So even though this is a tau molecule that we are measuring, it is better reflecting the tau that is abnormal in the presence of amyloid. So it seems to be tied to amyloid-related tau. This is from our own work in the Massachusetts ADRC, where over the years we've been collecting bloods, and we are now working with bloods from about 1,088 people, average age of 70, roughly half and half males and females. And so far we have run pTau 217 and 181 and a few other biomarkers in over 3,000 samples from these 1,100 people. We are relatively nicely distributed between people with no cognitive impairment, mild cognitive impairment, and dementia. And our first task was to basically look at the discriminative ability of these biomarkers in those patients or those participants for whom we had major biomarker confirmation of their Alzheimer's disease versus those without it. And when I say major biomarker confirmation, in our set, I'm talking mostly neuropathology, but we also have people with CSF and amyloid-beta and tau PET. And based on classifying people as AD versus no AD, on the basis of these three major biomarkers, if you will, we found, again, as other people have seen, good discrimination using pTau 181, excellent discrimination when we see pTau 217. And with this, we've been able to set cutoff Parkers. This is using the mesoscale discovery set of assays, the SPLEX assays. So we've been able to set cut points for more likely, less likely to have Alzheimer's disease, as well as specificity, and so you can see here, this is, I think, the 92.5% specificity is this maroon line, and this green line is 92.5% specificity for normal or non-AD. When we just look at the neuropathology itself, we've done this now in 242 cases. You can see the primary neuropathological diagnoses over here of these people. When we classify people according to the major categories of neuropathology, this is Alzheimer's, cerebrovascular disease, frontotemporal lobar degenerations, Lewy body diseases, normal, a variety of other things, as well as the tauopathies. pTau217 is highly specific for Alzheimer's disease. We do see some elevations in some of these, but you have to realize there's also substantial comorbidities for these cases as well. When we take Dr. Frosch's final diagnoses of whether there's Alzheimer's disease present, whether that's in diagnosis 1, 2, 3, 4, or 5, and we see that there's no AD in there or there is AD in there, then we divide them up this way. So this is neuropathologically defined Alzheimer's disease. We get, again, 94% discrimination among this. This is really outstanding. One thing I wanted to emphasize, I forgot to emphasize on this slide, I think the reason why 217 is such a better antibody or better assay than 181 is the dynamic range that we're seeing. So you can see that the concentrations in this range of AD versus no AD, goes from about 1 or less picograms per mil up to 12 or so. Here we're seeing, a 5 times greater dynamic range. And so things spread out a lot more, and that really helps in terms of correlating with other things, of course. So how does this compare? So how does pTau217 compare with still other plasma biomarkers that are around or imaging? And I'm not talking about amyloid or tau PET imaging or CSF here, because those are the things that we're benchmarking our plasma to. But pTau217, at least in the BioFinder study, in this study, let's just look at tau PET, had 93% accuracy. And then looking at cortical thickness through MRI, pTau181 in plasma, hippocampal volumes, or neurofilament light, the ability to detect Alzheimer's disease as defined by tau PET. All of these are, again, good and perhaps contributory, but not great. Same thing when we use amyloid PET here. And again, comparison among all there are now a lot of different kits. There's Fuji Rabio, there's Quanterix, there's Roche, there's MSD, there's C2N, there's a whole host of now assays, and they all do and this actually shows good correlation. This was a round robin. So about 40 CSFs and matching plasmas was sent to all these different companies to run the assays. And then the Alzheimer's Association and the investigators on this compared how they did. And as you can see from these correlation plots there, they're all really good. For 217. But it does look, when we look at the dynamic range, what we see is that the 217, I know it's hard to see, but the plasma 217 here, the green ones, all show superb dynamic range and specificity, and the 181s and the pTau205s and 231s are a little bit behind. There's been a lot of kind of consideration as what does it mean, these different phosphorylation states, and how much you mean, so is 231, does that appear earlier than 217, and does that appear earlier than 181? And I don't know. I'm not sure. I think that we can do some correlative analyses, but the data that I haven't seen so far have been convincing, and I think it may actually be more an issue of sensitivity of the assay to pick up the particular epitope than what stage of Alzheimer's disease someone has. But again, some tau specialists could probably tell me more about that than I certainly know. So what is now being proposed from a clinical standpoint is this sort of two-step workflow for the use of pTau 217, not just in clinic, but also in kind of selection for recruitment into clinical trials. So as we talked about, there's always this intermediate overlap range in terms of the pTau 217 and its ability to associate with positive or negative amyloid PET or neuropathology or whatever. And what happens? Who are these people in the intermediate range? What we know is that the way that these data fall out is that there are a lot of people with specificity in the that are high enough that we know that the likelihood is like 95 plus specific that they have AD in their brain. And we have the other end of the spectrum where 95% sure that they don't have AD in their brain. But the intermediates are the ones we want to know. So in this study, they actually looked at those people who's intermediate and what happens to them. So about 63% of them these are people in the indeterminate range for pTau 217. About 63% of them end up having positive CSF AD biomarkers as defined by A-beta 4240. About 86% of those have amyloid PET positivity. So again, you're seeing some discordance here, that some wiggling room that we really are not 100% sure. And then on the other side, 36% will have CSF negative for amyloid, but 86% will be negative for PET. So there's still, there's wiggle in there. We don't really know. We would like to know each individual. I mean, I want to know who this person is. Whoops. With some degree of certainty. So a lot of these things are, now what we're doing, we're trying to read what the neuropathologist is going to read, when he looks in the microscope. But it's to some degree we're making these because we're defining Alzheimer's disease this way, according to these biomarkers. So the workflow for using this in AD diagnosis is that you have patients with cognitive symptoms, get a pTau. If it's high, specifically high, then it's likely that they have AD, and you could perhaps move forward with treatment. Low, don't. Intermediate probability, that's where you want to get the CSF or the PET in order to convince yourself of what you're doing. pTau can also be used for prognosis. So if you take people that are either, let's just look at the people with mild cognitive impairment in ADNI, and you look at whether they had high or low pTau, plasma pTau 181 here, you can see that people with high pTau 181 tend to get worse over 5 years, substantially. People with mild cognitive impairment and negative pTau 181 tend to stay very stable. In our cohort, Pia Kivasak led this analysis. here. And, we divided our people with mild cognitive impairment clinically based on whether they were stable or whether they declined in terms of their CDR, Clinical Dementia Rating Scale, sum of boxes. And again, we found a significant difference, higher levels of pTau 181 at this time. We weren't using 217 at the time, between the stable and the declines. pTau 217 does better. So this is prognosis in preclinical Alzheimer's disease. So these are people without cognitive impairment who have amyloid positive PET scans or amyloid positive CSF. This is in Biofinder, and this is in the Wisconsin cohorts. And what we see is that if you're in the top quartile of pTau 217, remember, you're cognitively unimpaired, but you are amyloid positive, that your likelihood of developing cognitive decline is substantial. Now, there's still a lot we need to know about interpreting these levels in community samples and in real life, because there are things that can affect them, including and especially age, perhaps sex, perhaps race and ethnicity, perhaps medical comorbidities. And so studies like this are really great. So this is the Mayo Clinic study of aging, 1,329 participants. In this study, you can see the curve for all participants here, and you can see the numbers that we're dealing with, and how pTau 217 in cross-section changes over the course of the lifespan. It looks like it's pretty stable here until the 60s, and then it starts to go up. If you actually break it down, and here they had a subset of people that did have amyloid PET imaging, it looks like this uptick in late life is driven by the people that have developed amyloid here. If you look at some of the comorbidities that can affect or shift pTau 217 levels, and I know this doesn't show up very well, but one of the major factors that we do have to be mindful of and probably adjust for is creatinine and kidney function. So the excretion seems to be important in terms of shifting the pTau 217, allowing the possibility of false positives and negatives. There's some discussion about body mass index also being important. Cerebrovascular disease, here we have MI that looks like it shifts things a little bit. Diabetes does not seem to shift things so much. So there's still more that we need to know in terms of how to best interpret these. In terms of ethnic, there's a lot of talk and interest now in what happens because the differences in these biomarker levels, both not just blood-based biomarkers, but also PET and CSF biomarkers among different racial and ethnic groups. And so in this study, the BioHermes study, they examined 755 non-Hispanic whites, 115 Hispanics, 112 non-Hispanic Blacks that were different in terms of age and sex distributions and all. But I think controlling for that, looking at these blood-based biomarkers here, what this study found was that there were a significant, that pTau 181 and 217 was lower in people in the non-Hispanic Blacks compared to both the non-Hispanic whites and the Hispanic individuals. And so the ability of pTau 217 to discriminate is somewhat less And so we have to kind of be a little bit more cautious about that, and perhaps have a bigger buffer in the middle that we're accommodating to ascertain more definitively whether someone has AD or not. So the other data set now that we're doing in the lab. So our lab's working with the Aging Adult Brain Connectome project. This is a human connectome project, aging SPAN. And we've been running the AD biomarkers in this study. This is a study that looks at the mature lifespan. So these are people without cognitive impairment, without neurologic, significant neurologic disease, people that are in, I think the term is typical health, meaning that they're not super healthy. There's some diabetes, there's some cardiovascular, it's just typical health. If you don't have anything major active going on, you can come in. And there's about 1,200 people in this now. We've been working now with 902 people that have at least one blood. The average age is 66, but it spans from 36 to, I think, 105, actually. And the lovely thing about it, as you can see from these age categories, is that it's very nicely well distributed across the age span, as you can actually see here. And if we look at pTau 217, we can see a curve that looks reminiscent of that Mayo Clinic study, which saw this uptick in aging. And clearly it looks like something's going on once you hit around 60. It looks to me like there's an inflection around here. But even in the lower age categories, the 35 to 55, we still see a highly significant age correlation, that pTau 217 does go up and up as we get older. When we look at sex, race, and ethnicity, we find very modest effects. So there is some effect if you adjust for age, looking at males versus females. Males tend to have a little bit higher pTau 217 concentrations. We've looked at other biomarkers like GFAP, where men tend to have a little bit lower levels than females. Race, this has about 25 to 30% underrepresented minority group, which isn't bad. And when we adjust for age and sex, we not seeing a whole lot of difference. So we are not, at least so far, we do see, this actually is scatter plot unadjusted for these numbers are, these dots are unadjusted for age or sex. This is just the raw data. And I think it's largely, the elevation is largely driven by the overrepresentation of whites in the older categories here. But age adjusted, we do not see a real difference with the Black or African Americans, the multiracials. We may see a lower in the Hispanic Latinas. So again, we're keeping our eye on that. So this is now looking at, we have I think around 150 people across the lifespan that have had at least two bloods separated by 2 to 4 years. So this is looking at the stability within an individual over short period of time within the different age categories. And in all categories, with pTau 217, we are seeing this increase with age. And it becomes more dramatic in this preclinical era here, if you will, when we start to wonder whether amyloid is building up in our brain, but we do see this increase at the same time. And then the increase continues in older adults. We see something similar with GFAP, a little bit less with neurofilament light, which I may or may not touch on. So we've talked about the development of these biomarkers, pTau 217. We've talked about its role in diagnosis. We've talked about its role in prognosis. We've talked about some of the considerations that we have to make when in interpreting this. What do we see so far in terms of its use for treatment monitoring in people with disease-modifying therapies? So I'm going to show you the phase 2 data that's been reported from donanemab Trailblazer study, as well as the lecanemab study 201. I think we all, without looking at the details of this graph, you'd say, oh, that looks like what they reported for the amyloid imaging. But this is pTau 217, where over the course of the 76 weeks, the people that were on placebo, their pTau 217 really did, well, it may have even increased a little bit, whereas there was a dramatic decrease in the pTau 217 levels in blood that really parallels, but is shifted a little bit later than what the amyloid clearance, I think, shows on the amyloid PET scan. And this, I think, is even more interesting if you look at how it changes after discontinuing the donanemab, because in the donanemab study, I think they stopped at when people cleared amyloid by PET or at 24 weeks. No, that 20. Yeah. So in the people that stopped donanemab after 24 weeks and the people that continued after 24 weeks, this is the pTau 217. Again, we see no change it's basically the same curve here, but this is comparing those people that discontinued at this point. And curiously, the people that discontinued in the hatched line, basically stabilized at that point for another, 50 weeks. It didn't go back up. The GFAP started to go back up. So I find that interesting, and find it interesting. The blood-based biomarkers in lecanemab, here they use pTau 181. So remember, not as much range, dynamic range, but again, saw a dose-related, let's see, this is actually the A-beta 4240. Sorry about that. This is the A-beta 4240 biomarker that increased a little bit. This is not, sorry, this is an error here. But this is the pTau 181 that they measured in the open label extension trial. So you can see in what happens to pTau 181 over time. This was in the original study, placebo-controlled. Then the study ended. There was a gap with no treatment. The pTau 181 seems to be going up, maybe. And then people entered into the open label extension where everyone received active treatment. And we see here a dramatic decrease in the pTau 181. In the people that were treated originally, they declined significantly, and then remained relatively stable, maybe drifting up a little bit, and then stayed low in the open label extension. So, pTau 217 is looking like it's ready for prime time for me in terms of using it for diagnosis, informing us for prognosis. There will still need to learn more, and perhaps for treatment monitoring to ensure that, do you need a PET scan in order to see that, the drug is working for someone, or can you just do a blood test? I'm just going to mention and close with two other things that again, are informative, but we still need a lot more learning about. So neurofilament light, of course, has been extremely successful in ALS and even monitoring treatment response for ALS. It's now an established outcome for ALS trials. This is an intermediate filament, basically packing material for neurons and axons that when they are released, when they are injured, they release this neurofilament light. Neurofilament light actually has a fairly long half-life. It's on the order of like 5 or 6 weeks, so it hangs around for a while. So you're allowed to see it accumulate if there's some kind of active neurodegeneration. It's measurable in CSF. It's extremely high in ALS, in Creutzfeldt-Jakob disease, in MS. It's also high in AD and Parkinson's disease relative to normal, but not that high. So it has not been a great biomarker in Alzheimer's disease. This is what we see in the AABC cohort. This is what we see in our MADRIC cohort. We see compared to normals that it is elevated and it is significant. But what really stands out are the frontotemporal lobar degenerations here, which have high NFL. I'm going to just mention, again, GFAP is also something that is very interesting. It shows a good dynamic range. It changes substantially over the course of the lifespan. It does seem to have some associations with sex, ethnicity, race. And in our earlier work, we did see a significant change with or association with prognosis. It was helpful for prognosis. So I'm going to share what my conundrum or my confusion is. So GFAP is supposed to reflect astrocytosis, right? Astrocytes, when they're injured or diseased in disease states, you get an upregulation of GFAP, and it increases. Well, that's something that happens not just in Alzheimer's disease, but also in many other neurodegenerative diseases equally, I would say, perhaps even more. And yet we see this relative specificity in Alzheimer's disease. So we saw the neurofilament light really high in FTLD. And here, it's a little bit higher than, well, a little bit higher than, they're all a little bit higher than normal, but it's really AD that stands out. And that's always perplexed me. Why is it, if it's a general marker of some kind of, astrogliosis, why do you see it, especially, is it just that Alzheimer's is more aggressive, affecting more areas of the brain, and so there's more that's produced? Or is it something related to the presence of amyloid or tau or just the whatever the pathophysiological process of AD is? So, I think this is why, like, GFAP and neurofilament light, these non-specific markers of neural injury and response, are still confusing. Because we see these disease specificities and we just don't understand them yet. So I'm going to stop at this point. Synaptic biomarkers are another area of interest to us, but there's still a long way to go in terms of blood-based biomarkers of synapses. But this is one of the holy grails that we're working towards. And then I always put this slide in my talks showing that Alzheimer's disease is more than amyloid and tau. There's a host of factors that are driving the neurodegeneration, and having good biomarkers of these processes is still a real challenge, particularly neuroinflammation. So just to acknowledge folks in the lab, Pia and Mahesh and Joanna, Bruno and Hadia, and then all the other friends, colleagues, collaborators that we have here. So I'll stop at this point.
Steve, thanks for that whirlwind tour of 20 years of biomarker research, 58 minutes. One thing I was curious about that, it looks like your pTau 217 data are ready for prime time, as you said, to make a diagnosis that is in the presence of some Alzheimer's disease. It's higher. But does a high 217 mean that this is going to be a worse disease? Does it have any predictive value? So I saw that there was a prediction of a high 217 with the likelihood that a cognitively unimpaired person would develop symptoms over years. But if if we have three patients and one of them has a high and one of them has a above your threshold, but not super high, and one of them super high, does that tell me what's going to happen to those three people in the next year? Or does it just tell me that they all have Alzheimer's disease?
I think it tells you that there's a very high likelihood that they have Alzheimer's disease in their brain. I did not show this data, but in our neuropath data from MADRIC, we do see an association of the level of pTau 217 with Braak stage, so how extensively it has been, the AD or the tau pathology has spread through the brain. We do see some association with Thal phase for the amyloid in the brain. So it may be helpful, but I think there's a lot of noise there, a lot of variability in terms of staging the disease and the degree to which the stage or how much tau pathology or amyloid and tau pathology there is in the brain. If that is an indicator of what the progression is going to be subsequently, then yes, it is useful. But we all know that, you look at the correlations and there's a really strong correlation between cognition and how much pathology you have in their brain, but there's a lot of variability as well. And so that's, and to me, that's what the contributing factors, whether it be the vascular, cardiovascular metabolic factors, I think are incredibly important. One of the things I'll say, the pTau, and we've been looking at that, P is also looking at this now. Vascular pathology is everywhere. It's like 80% of our cases have, some kind of cerebrovascular disease that Matthew identifies. And what is the influence on that in terms of how does that shift the correlation of AD pathology with the clinical syndrome, which of course, at the end of the day, the people we see on Wang 8, that's what's important, right? It's not, that's an issue. So another question.
Great talk. I had a question where are we at in terms of insurance companies covering things like the alternative PET scans in terms of amyloid and tau? Because we've been relying on sort of FDG PET scans for ages. So where are we at in terms of insurance companies actually covering these alternative PET scans?
Oh, Medicare does cover amyloid PET scan. Some insurance do. So if you're over 65, yes, it's covered. If you're under 65, maybe. And Jeremy might know better than I do there. But CSF is typically covered, which is, I think we learn a lot from CSF. And then there was something else that I was gonna, I can't remember. So yes, it is covered. So these blood tests, I was going to say tau PET is approved for clinical use, but as far as I know, no insurance company is covering it, and the company is not planning to fight that fight. So I think that that's still mostly going to be a research tool for now. Blood tests, so C2N, Quanterix is now developing commercial CLIA-based, testing for pTau 217. Fuji-Rabio, probably within a year, they'll have a CLIA-approved test for pTau 217. I don't know what the insurance coverage is going to be for that yet. Quest has a bad assay that measures amyloid, and it's one of those you can get it yourself. You don't need a doctor's prescription to get it. Yes.
Thank you very much for a wonderful talk. I'm actually a PhD student visiting from Scotland, where I'm currently doing a lot of biohermes research as part of the Biohermes Data Challenge.
I'm sorry, the echo here is incredible.
Can you hear me better now? I can also just speak up. Is that better?
That's better, yeah.
So I'm a visiting PhD student from Scotland, where I'm currently using the Biohermes data set and looking at it quite intensely as part of a data challenge that we have in Scotland. And what we notice is that so many companies and providers gave data, biomarker data, for the Biohermes challenge. So when we actually compare data from different providers, there's quite a lot of measurement variation when we analyze the data. So I'm wondering, from a statistical point of view, do you think that we should always control for sites when we use multimodal data collected from across the world? And how do you see the future of this?
Yeah, so that's actually a really good point in terms of how so there's site-to-site variation, there may be batch-to-batch variation. Those are the things that the companies need to do in order to kind of move this into a CLIA approved. There have been a few things that have limited the development in the field. One is the lack of a certified material, standard. I can't remember blanking on the official term, but basically, a certified amyloid against which you can, kind of with each batch of assay that you make, you can kind of scale it to that. That is what we need. We don't have any certified reference material. That was the term, certified reference material for tau. I think there's amyloid-beta 42, but not amyloid-beta 40. So again, we're moving.
Sorry. So I was wondering, thank you for the great talk. Sometimes in literature, we see that electrophysiological features or signatures as measured in EEG or MEG maybe could maybe help with the diagnosis or detection of early Alzheimer's disease. Do you have any comments on that, specifically with respect to now these fantastic plasma biomarkers, which seem to be quite developed? Is there would there be an advantage in terms of early diagnosis with other biomarkers, I guess?
Yeah, so, different kind of quantitative EEG measures have, in the US, they haven't had that high a regard because the noise and the inconsistency, talk about site variation, just the way the data is collected varies so much. In Europe, it seems to be appreciated a lot more. I really love the idea of EEG-based because theoretically, conceptually, mechanistically, it's like where the action is. It's just the measurement is so difficult and noisy. And when you look at the way different kind of, quantitative EEG measures or evoked response or evoked potentials or quantitative EPs, it just doesn't, the data's not there to the high enough association to say, I'm gonna put you on an anti-amyloid immunotherapy because your EEG, power, spectral power was this, that, or the other thing. It's not ready. And, I don't know whether there's just any kind of, it'll never be ready, or it's one of those great ideas that is still a great idea.
One more quick question. Thank you, Stephen, for the wonderful comprehensive review of these biomarkers. Back to your point about pTau 217 being ready for prime time, could you just go into a little bit more elaboration on that in terms of clinical translational thinking there? You think it's ready for prime time in terms of enriching populations that are destined to progress quicker, or do you think that the biomarker is useful for target engagement of a therapy, or both? Could you just speak to that a little bit?
Yeah, so both, I think both of those points, Gene. So one, it is being used definitely as an enrichment strategy so that you don't have to screen 1,000 people with amyloid PET scan. You can just do a blood test and immediately get rid of, the people that are low, or and keep the people that are high. It depends on what your stringency wash is. How certain you want to be. If people with a high pTau, do you want to get them all? Then do you want to get them an amyloid PET and then MRI and everything? So I think that I do feel that it is, and it actually is in different clinical trials, it is now being used as a sole entry criteria. So Lilly has a preclinical AD trial with an anti-amyloid agent, that is solely based on the presence or absence of a high pTau 217. So this is being used now by the big companies. To your point about the target engagement, I think it's in the donanemab and lecanemab data. That clearly shows a decrease in amyloid by PET scan, and an almost concordant change, maybe not as dramatic, but a concordant, and again, that may have to do with dynamic range, but not as much. But a highly concordant decline in the pTau 217. That is compelling to me, those data. Now, if we wanted to really start talking about clinical, so that's the target engagement aspect of it, is that engaging the disease or the syndrome. We know that the anti-amyloid immunotherapies, even though, so a couple things, actually interesting things. We know that you clear the amyloid, people don't get better. They some maybe stay the same. Some continue to get worse, and others just get worse a little bit slower. And so it seems to me that it's obvious that Alzheimer's disease is more than, or Alzheimer's disease syndrome is more than plaques and tangles. Okay, there are these other factors that we have to consider. So that's important. Yeah. Okay. Sorry. So there was another important point an even more interesting point that I totally lost.
We'll save that one for your next talk, Stephen.
Yeah.
I just want to thank you again. That was a great talk, and maybe if there are other questions or people online can email you and follow up. But
yep. Okay. So one question from Mike Schwarzschild, ApoE. I didn't show any ApoE data, but ApoE is having the 4 allele is a driving factor for Alzheimer's disease. And yes, whenever we compare ApoE4 versus negative, we see higher pTau 217. No real surprise in that. And then I think also in terms of modeling diagnosis, prognosis, it does, it's a worthwhile addition in the model.
Super. Thank you so much, Stephen.
Okay. Okay.